Afternoon, everybody. We are right on time. We're going to get this show started. My name is Jamie Terrell. I lead marketing and communications here at Saltmarsh. We appreciate you joining us for today's webinar on mandatory compliance for skilled nursing facilities. Here with us is Claudia Reingruber of our healthcare consulting team. We're glad to have her leading our presentation. I know Claudia has a lot of new information to cover, so before we get started, we have just a few housekeeping items for everyone. First, all of our attendees on the line have been muted. If you have questions throughout, please share them with us in the Teams chat. And if we have time toward the end, we'll address some of your questions together. We also have Claudia's contact information available in the slides. And of course, you're welcome to contact anyone on our team, Andrew, Al, Claudia, Felice, Becky. They're happy to provide additional guidance following today's webinar should you have any questions you'd like to address with them offline. Today's presentation is also being recorded, so you'll receive a copy of that recording along with our slide deck tomorrow. And of course, if you've enjoyed our webinars, please take a moment and tell us if there's anything we can do to improve, and we would love to keep providing these for you if you enjoy them. So with that, I will hand things over to Claudia, Managing Director of our healthcare consulting practice, to get us started. Claudia?
All right, thank you so much, Jamie. We are so glad everyone is here today. I know this is probably not the most exciting topic, and with all the other challenges that you are facing in this post-acute world today, we really appreciate you taking time to learn a little bit more about mandatory compliance and what to make sure that your team is ready. So in looking at what we're going to be talking about today, we are going to go through a brief history of healthcare compliance, just very briefly to give you a foundation for why compliance is so important. It isn't just healthcare. It arose many, many years ago, so we're going to look at some of that background briefly. And the requirements of participation are the reason why we have this mandatory compliance and ethics program requirement. We'll briefly look at what that says and what the components of that are in terms of how you make sure that your compliance and ethics program is effective. We'll talk a bit about risk assessment under PDPM, but I added "and more" because there has been a lot of information that's been published regarding the CARES Act and the provider stimulus funds and provider relief funds and all of that goes along with that. And those funds that you have received under the various programs, whether they're loans or under the CARES Act, whether they are grants, carry with them a lot of responsibility. And there has been some recent information published about what those obligations are. So we've added some additional slides. And in doing so, that means we're going to go through the PDPM risk assessment process a little bit slower, but you have all of the slides. So you can review them in more detail later. And if you have any questions, you can always call and we can clarify anything after the presentation is over. And compliance and auditing and monitoring is a very important part of making sure that your compliance program is effective. And demonstrating effectiveness is something that you are required to do. The government has given us a lot of tools in order to do that. There's a lot of information of potential risk areas and potential areas for what the government might view as improper payments or abuse, and they've given you these tools and this data so that you can look at the data and see how it applies to your facility and help you determine or make sure that your compliance and ethics program is, number one, that you're monitoring the statistics that you should, and that you have the appropriate protocols in place that you will identify, hopefully, if there is a problem, that you will identify it and then take steps to correct it. And then you'll be able to continue on. And so that is, it's very important to make sure that your compliance plan truly is effective at detecting errors, which we know will occur. And we'll briefly go over the Medicare overpayments rule and what is referred to as a 60-day refund rule, which means that once you have a known overpayment, you have 60 days. Basically, once you have an overpayment amount, you have 60 days to refund that to the government. And that's for the Medicare program. And at the end, we've provided a lot of resources for additional information. There are a lot of reference materials that we're going to talk about here and links to information. And those of you that have been monitoring this know that the information changes practically daily. So it's important to have these links. And if there's anything we cover here today that you would like more information about, or that you're not clear where to find it, or you have any trouble at all, please let us know. We have teams that monitor. We have a healthcare team that monitors all these rules daily. That, this is basically where I spend a lot of my time, and we have others on the team that do as well. Understandably, as you carry out your day-to-day functions, it's near impossible to monitor all of these changes that are occurring. We're in a very different place today than what we were 6 months ago. And so for that reason, we always will give you a citation or an official source of information to go to. It's best not to rely on what you might hear from the facility down the street or a friend or whatever. There's a lot of misinformation out there that gets kind of muddied up, and so the best thing is to go to the official source and find out what the government and the various programs have to say about these issues. And so with that, we're going to go through a brief history of compliance, just in case you thought that perhaps healthcare is the only industry, and I'm sure you didn't, but healthcare seems to be a very heavy topic right now in terms of doing the right thing and making sure that our practices are compliant. But there's a lot of history that got us to here. For example, there began fraud actually we had a lot of fraud in the defense industry in the 1980s. And in the 1990s, fraud, I think it was in 1994, fraud in the healthcare industry was designated by the Department of Justice as their #1 priority, second only to violent crime. So healthcare fraud has been on the top of the government's focus area list for a very long time, and it continues to be there. And I'm mentioning the federal sentencing guidelines because when they were modified in 1991, they do allow providers, give them an opportunity to get credit for having an effective corporate compliance plan in place if you do end up being investigated. And in 1998, we got our first compliance program guidelines for skilled nursing facilities. That was updated in 2008, I believe that should say. And the ACA, the Affordable Care Act, came out, and that's what mandated that we have this effective corporate compliance and ethics program. And then we got the requirements for participation in long-term care that were updated to put into place that mandatory ethics and compliance program. So with that, one other comment I want to make is that in case anyone might think there's been a slight downtrend in the amount of investigations and False Claims Act prosecutions and cases that have gone down since April, when the pandemic, when we really got into the throes of the pandemic. But the focus on compliance in the healthcare industry, and particularly in long-term care, is going to continue in the future. One reason for that is that the amount of money, the return on investment that the government entities spend on enforcing compliance, their average return is $4.2 for every $1 they spent. So it's worth them to put money into enforcing compliance, and I think you're going to see that continues to happen. A brief overview of fraud and abuse laws. In order to understand how you might be impacted by potential liability under the False Claims Act, it's important to understand what these basic fraud and abuse laws are. And this is not going to be an in-depth discussion, but just a brief overview of the ones that have the most likely impact potentially on post-acute care and skilled nursing facilities. So the first is the False Claims Act, and that is a very potent and powerful weapon that the government has to investigate and prosecute both civilly and criminally when claims have been submitted that are considered to be false. And it's not a recent development. It actually came about in the Civil War when there were profiteers who were selling the federal government defective horses or lame horses, or selling them boxes of ammunition that were empty or filled with sawdust. So this has a very long history, and it was modified in 1986 and given more teeth. So the False Claims Act is probably one of the most certainly important weapons that the government has in investigating fraud and recovering money. And there's also the anti-kickback statute, which has a lot of effect on business relationships in healthcare. Things that don't apply in many other industries can become very problematic under the healthcare industry. So this prohibits a transaction where on either end of the transaction, where someone is rewarding, for example, if there's a provider that rewards a referral source for referring to their Medicare or Medicaid business or other federally subsidized programs for providing services to those entities. So it's important to make sure and review your contracts and to have an attorney involved in reviewing your contracts to make sure that you don't have any provisions of them that could be viewed as a violation of the anti-kickback statute. And also there's a federal anti-kickback statute and there's a state anti-kickback statute. So lots of potential liability in there when you're arranging business, when you're entering into business relationships with a variety of entities. There's also an exclusion statute. You can be excluded from participating in the Medicare and Medicaid program, which can be pretty much like a death sentence or an end of your earning ability going forward. So the exclusion statute is also important to keep in mind. And there are civil monetary penalties law. For example, they can seek civil monetary penalties for prohibited contracts or transactions. It can be under the False Claims Act, the anti-kickback statute, but civil monetary penalties can be a very expensive lesson if you end up running afoul of any of these laws. So fraud and false claims act liability, which is really the one that we will probably spend the most time talking about today, is when someone quote unquote knowingly submits or causes to be submitted a false or fraudulent claim. And when we're dealing with the False Claims Act, intent is not required. And knowingly means it's someone who has actual knowledge that a claim is false or reckless disregard of the truth or falsity of the claim or deliberate ignorance. What is reckless disregard of the truth or falsity? You know, those of us, if you've been in the Medicare program for any length of time, you know that we're very heavily regulated and that those regulations come to us mostly on the internet. We don't get hard copies of manuals anymore the way we did many, many years ago. All of the information that we are obligated to follow comes to us through the internet, through the Centers for Medicare and Medicaid Services, through your Medicare administrative contractor, and it's important for us to check those websites and to be on listservs and to be on their mailing list, so when something new happens or there's a new regulation, that we're aware of this. So it's not enough to knowingly means that you cannot have a reckless disregard for the truth or falsity or the regulations that you're obligated to operate under. And to give you an example of how this is how the government views deliberate ignorance. This actually came from a CMS presentation to physicians to illustrate what deliberate ignorance is. So we don't want to fall in that category. The False Claims Act violations also can include not just submitting a false claim, for example, a false claim for services that weren't provided, or services that were billed at a level higher than what was medically necessary or warranted, or any of the variety of those kinds of violations when you submit a claim. But in addition, if you submit claims and the government determines that your care is worthless or worth less than what you're being paid for it, then this is you can actually have a potential False Claims Act violation for the submission of claims for substandard care. And in March of 2020, I know we've had a lot of water under the dam since then, but Attorney General Barr published a memorandum indicating a new initiative that they were going to focus on problematic nursing homes that provide grossly substandard care. And they have been a number of recent cases recently in the last several years that you might want to read to get an idea of the kinds of things they prosecute, but this is not where you want to find yourself in that kind of situation where there are allegations of worthless care. And it's a very, especially now in the times that we're dealing with, where we have all of these other priorities and all of the other things that we related to the public health emergency that create all sorts of other areas of potential False Claims Act liability. It's very important that we pay a lot of attention, as I'm sure I know every one of you does every single day, or you wouldn't be in this business, that we know how important it is to take care of the elderly that are in our charge. And we work very hard to do that every single day. So this is a focus area, something that's going to continue, even though we haven't seen as much activity recently, but grossly substandard care is something that the government intends to pursue. And one other potential variation, or a variation of the False Claims Act, is what some people sometimes refer to as a reverse false claim. And that can be where you retain a Medicare overpayment without refunding it. So you have a known overpayment, but you don't refund it. And that can be viewed as a reverse false claim. So that can trigger liability as well. And with all of the stimulus funds that have been distributed here recently, this can create additional liability for providers to make sure that they're appropriately handling these relief funds and stimulus monies that have been issued, to make sure they're complying with all of the guidelines. And if they feel like they've received, if their determination is that they've received too much money, and there have been some cases of that, then it's important to refund that overpayment so you don't get into this potential liability for reverse false claims. And if we look at how successful this program, the False Claims Act, has been in previous years, you'll get a sense of why there is still so much activity with respect to False Claims Act litigation. First of all, many of the False Claims Act cases that come from whistleblowers. So whistleblowers are people who may work for a provider and may have identified what they think is an inappropriate practice. Oftentimes they go to management and try to talk about it, but if they don't seek, if they don't get the kind of feedback that they feel is appropriate for a situation, then they could decide to go the route of a whistleblower. And in a number of the False Claims Act cases that we've been involved with, they oftentimes do start from someone who is inside an organization, feel strongly about what they suspect is an improper practice. They go to management or the compliance, through the compliance program, make their feelings known, but nothing happens with respect to it. And that is where some of these False Claims Act cases, where they end up turning into a False Claims Act case, because perhaps the provider did not pay enough attention to them. And when you look at the amount of recoveries, in the fiscal year of 2019, the government recovered $3 billion in False Claims Act recoveries. And what's important about that statistic is that almost 90% of it, 85% or more, came from the healthcare industry. And that's a staggering number. If you realize the importance of that, you know that we are going to be in the crosshairs for a period of time to come, particularly in post-acute, because the error rates in post-acute in many service areas tend to be higher than the average error rate, which we'll explore that a little bit later on. And nearly 75% of those recoveries come from what are the legal term for what is called PDPM lawsuits, which are those whistleblowers. 75% of the recoveries come from that. There are so many PDPM lawsuits that are filed. The government has the right to intervene and take over the prosecution of those cases, but there's so many of them that they are not able to do that. And so sometimes these PDPM lawsuits proceed with an outside attorney. So 75% of that $2.6 billion was initiated by a whistleblower lawsuit. The largest settlements have been with pharmaceutical and medical device companies. They're very big, but there have also been some very large settlements and painful settlements for skilled nursing facilities and other entities in the post-acute sector. So even though these other larger companies have been a focus area, it's not do not think that that nursing homes are out of the radar because of that. There's been a number of cases, quite a number of them, that have involved nursing homes. And in 2020, year to date, in that fiscal year, we've seen the general consensus is, from what I've read, is that these enforcement efforts by the Department of Justice have declined in the second quarter of the calendar year, starting at about April. Now, does that mean that that they're not going to continue in the future? No, I think it just means that right now, you know, we had a lot of flexibilities and that were in place at the beginning of the coronavirus, when that public health emergency was still, you know, was first enacted or put into place. But we know, for example, now that surveys are resuming. We know that medical review is resuming since the early part of August. They originally had put that on hold to give providers an opportunity to get ready for the to be able to, you know, deal with the coronavirus, but medical review is again underway. So we expect that recoveries and enforcement efforts are going to continue. So mandatory compliance and ethics program, what exactly is required here? Everything that we covered preceding this was just to give you an idea of some of the claims and payment related risks and liabilities that may exist when you participate in the Medicare program. And the mandatory compliance program was, we knew this was coming. We've had advance notice of this since the Affordable Care Act was passed. It took a while to get the actual rules published, but the rules have been published, although there's some, you know, there's a little bit of confusion as to whether or not those may be modified or what the current status is. The final rule that implemented those is out. And so the best thing to do to protect yourself is to make sure that you have an effective compliance and ethics program. That will buy you a lot of credibility in if you do have a potential problem. So if we look at what the Code of Federal Regulations actually says, it says that a program, in order to have a compliance and ethics program, it should be reasonably defined and implemented and enforced. So it's likely to be effective in preventing and detecting criminal, civil, and administrative violations under the Act, and in promoting the quality of care. So it doesn't mean that in order to be effective, you have to detect every single error that occurs, and that it will be effective in preventing errors from happening in all instances. But it means it's that you have you've evaluated your risk, you've been reasonable in defining the processes and procedures to audit and monitor those risk areas, that you're going to look where you should be looking, identify the types of claims that are likely to lead to erroneous payments, and that those are the areas that you're monitoring and focusing on. And that it also means that as circumstances changed, and certainly in the last 6 months, a lot of circumstances have changed, that you go back in and you take another look at the program and see what you need to modify in order to make sure that any new risk areas are appropriately covered. This became effective November 28, 2019. And just briefly to go over what the elements of a corporate compliance plan, there are really 8 specific components at a minimum that you want to make sure you include. We're not going to go through these in detail because we don't have enough time, but I wanted to make sure you at least had them so that you could review and make sure that you have the appropriate elements in your plan. Now, risk assessment under PDPM. Of course, all of these things happened, you know, within the same year. So we had the conversion, a hard, fast conversion from RUGS 4 to PDPM on October 1st of last year. And then we started to have the beginnings of the pandemic in January and February of this year, so of year 2020. So we've had a lot of things going on. This PDPM switch, as we know, was a significant change. We know our rules change all the time, but this is a little bit different in terms of the scope of what changed. And then on top of it, we have COVID, which really created a very challenging environment. And one important fact about when you're at greatest risk is that whenever there's a public health emergency or an emergency of any kind or a stressful situation, that's when your risk is heightened in those kinds of scenarios. And so today, nursing homes are in an environment where our risk has been heightened, and it's important that with everything else that we are dealing with, that we don't lose sight of compliance activities and make sure that we really prioritize what is the most important, and that's where we spend what limited time that we have in order to make sure that we don't end up billing inappropriately or having a compliance related problem. So risk assessment, we know that this, and I'm going to go through these slides very briefly for the next 10 or so because we want to have enough time at the end to go through some of the newer material. But just briefly, anytime you have change, you're going to have a higher risk of error. And CMS has planned a very robust monitoring. We know all about the shortcomings of Rug 4. We know about incentivized therapy delivery and that our practices have likely changed before the advent of COVID, and that the system under PDPM really rewards quality and not quantity. So under PDPM, the focus is on value. It's on quality versus quantity. We're really trying to correlate our payment and our resources with patient characteristics, which it does a better job of. And there are some technical aspects of the program that we want to make sure we comply with, the variable per diem rate, a variety of other areas. Just in case you think CMS will not focus on this or might grant some lead time, give us some latitude, they have indicated that they plan a robust monitoring program and that they're going to take a look at what we were paid under Rug 4 and compare it to PDPM. And when they published the rule for the next fiscal year, they indicated they did not feel that they had enough data yet to publish any real information about how, or to make any conclusions about any trends during that changeover from Rug 4 to PDPM. But you can be assured that they're doing a lot of data mining, they're monitoring, and they're not just monitoring payments, they're monitoring utilization. They're monitoring quality trends, and may determine that, and they may use and will undoubtedly use that information to identify providers that they intend to investigate. One other tool that they have in their arsenal is that they can make adjustments by rebasing or recalibrating the system if they believe reimbursement is too high. There's not that budget neutrality that's anticipated. So if they determine that based on information probably during the next year, after we've had more time under PDPM, if they see that budget neutrality requirement has not been satisfied and the payments are higher under PDPM, then they can always recalibrate or rebase those case mix weights, and they can make a case mix creep adjustment, which they have done under home health. So it's important to make sure that we monitor our billing and our services, et cetera, under PDPM to make sure we comply with all the rules. And the government expects that they'll be very well positioned. And it's not hard to believe because they have a lot of information at their disposal, information we don't have full access to, most of us. And so as a result of that, it is important we pay attention to what they identify as problem areas, because that will give us hints about where we should be looking at our operations and seeing what areas indeed could be potentially risky in our operations. So how do you conduct this risk assessment? You have, you're going to be looking at service utilization. Quality trends, as I mentioned, are very important, especially when you think about the potential for worthless care cases. So they're going to be looking to see what the quality is like, the 5-star, the quality measures, et cetera. Looking at that payment for budget neutrality, and looking to see what kind of changes there may be in practices such as service delivery or coding under PDPM. So just going through these, as I said very quickly, we want to monitor service delivery and utilization under PDPM, and particularly as it relates to therapy. They have identified trends for us to monitor. We know they're going to be looking at how much therapy we're providing on our assessments, and they can do that. And we know they're going to be looking at our changes in our quality of care and the QRP outcomes. And the areas of payment vulnerability, they've identified they're going to be looking for increased coding in certain MDS items and other inaccuracies in ICD-10 coding. So they'll be looking at that. And they'll be looking at the interrupted stay policy. Are we properly applying it? They also indicated that we're going to look for atypical utilization of interim payment assessments. I don't think that doesn't seem to me to be a real high risk areas in most situations, but one they've included on their list. And they importantly will be looking at changes in service delivery and lengths of stay for similar patient conditions under PDPM. What were you doing for a hip replacement before and after PDPM? What are you doing for similar situations or similar conditions that patients were treated for in the hospital? What are you doing today for those patients when they come to your facility? And this is an area that I would highlight a little bit. Nursing documentation needs to evidence daily skilled assessments or the provision of daily skilled care. When we were under PDPM, therapy carried us when it came to evidencing and documenting a daily skilled care because our therapy orders, 95% of our patients were getting therapy. So in that particular situation, they were getting them mostly 5 days a week. And so when that occurs, therapy is documenting the daily skill and providing evidence that a daily skill has been provided. So if nurses did not always conduct a daily skilled assessment on post-acute patients, then that wasn't as much of a potential problem as it is in the world of PDPM. And so that is an important focus area. Now we have the implications of the public health emergency. We do have Section 1135 blanket waivers of the 3-day hospital stay and the spell of illness as well. And those are under the Section 1862F. And we have another couple of slides on that coming down the road. Important to make sure you're using those waivers and using them properly. Ineffective infection prevention and control can be a problem, and we've probably heard everything we want to hear about infection prevention and control, but that can be a potential area of vulnerability. And right now we're dealing with declining occupancy rates, and we have all these increased risks due to the financial and operational pressures that we're operating under. So lots of things have created kind of a perfect storm for potential concerns under for payment payment areas of improper payment or improper billing under the Medicare program for Part A patients. So attached as Exhibit A, and you won't be able to see it now, but you will get this after the seminar. We've identified a listing of some of the risk areas that may occur under PDPM. You'll want to review those and see if they're, which of those are most likely to affect you, given all the other constraints that you have at the moment. Make sure you're really focusing where you need to, where your risk is highest, and that you monitor those areas. And, that we do the best we can under the circumstances that we currently operate under. And some other things to remember are that under the coverage criteria have stayed the same, that we still need a 3-day qualifying hospital stay. I've asterisked there that we know there are waivers that apply under Section 1862, the blanket waivers that apply, but absent that, the same rules apply as they always have. Patients have 100 days available per benefit period. We have to have a daily skilled care delivered that is medically necessary and reasonable for the patient's condition. And more importantly than that, or at least as important, is that it be documented in the record. That, I think, is the biggest concern, is not that we're not doing the daily skilled care we should be, but that we don't always give ourselves credit or document for what we do. The definition of daily skilled care has not changed, and of course It needs, anything you build to the Medicare program has to be medically reasonable and necessary. We still have the requirements of the practical matter criterion. So our skilled services necessary on an inpatient basis. We still have to get physician certifications and recertifications. We have the administrative presumption that still applies, and other documentation requirements still apply as well. So let's take some time now to talk about risk assessment taking into consideration some of the implications of COVID-19 and the CARES Act. There's some statistics that are available also from the Healthcare Compliance Association. That organization did a survey in the last several months of members of the Healthcare Compliance Association, and they asked the compliance officers what their compliance responsibilities were like today. And do they believe that their compliance areas of risk have increased? And 67% of respondents said that they do believe that their risks have increased. Only 10% believed that risk was only increased. Let me say it a different way. 67% said that their risk had increased some, and an additional 10% said it increased significantly, and the other remaining individuals said that it has stayed the same. So most people today believe if you're a compliance officer, your risk has changed under everything that we're dealing with today. And then the next question, and another question in the survey was, has your budget been affected? Has your budget been increased as a compliance officer? Only 7% of respondents said their budgets had been increased as a result of this heightened risk. 2% got their budgets increased greatly, and 5% only got their budgets increased slightly. And 53% of the respondents said as a compliance officer, budget hadn't changed at all. And 40% of the respondents said that their budget had been reduced. 25% said it had been reduced slightly, and 15% said it had been reduced greatly. So when you think about those statistics, that makes in these difficult times when budgets are so constrained, it makes our responsibilities for compliance activities even harder to achieve. So it just increases the importance that we're focusing on the right areas. So what has the Department of Justice indicated are going to be their priorities in this COVID environment? So since we've had the public health emergency, this is what the Department of Justice has indicated they're going to prioritize in terms of all of their efforts. They said they're going to remain vigilant in detecting, investigating, and prosecuting wrongdoing related to the crisis. And we know there's been a lot of wrongdoing related to the crisis. We've read it in the newspaper. We've heard it from anecdotally. There have been people who are abusing the stimulus funds and provider release funds, and they are being detected and being prosecuted. The DOJ has also appointed a coronavirus fraud coordinator who will be appointed in each district to coordinate enforcement and conduct public outreach and awareness. I think to coordinate enforcement is going to be a very important piece of that. And there's now a national system where whistleblowers can report suspected fraud. And these False Claims Act actions will also be prioritized. So if they identified fraud related to COVID-19 and you do business with the federal government, then you are subjecting yourself to liability under the False Claims Act. I'm not suggesting that anyone on this call will be doing that, but I'm saying that that's what the Department of Justice is going to be doing. And the CARES Act included a number of provisions to fight fraud. There are new entities that have been created to oversee these programs and investigate potential fraud. We have a new special inspector general for pandemic recovery. We have a new pandemic response accountability committee, and we have Congressional Oversight Commission. All of these entities are brand new, and they were funded through the CARES Act. So they have money to take out, they've been given the sufficient funds in order to undertake these activities. But beyond that, the U.S. Comptroller General also has authority to audit. And there are other existing enforcement and regulatory bodies that don't plan on ignoring COVID-19 and plan on evaluating and investigating misconduct that may be associated with these relief funds. We want to just take a minute and talk about the appropriate use of these Section 1135 blanket waivers that are applied to skilled nursing facilities under Section 1862F, because those are significant for SNFs. There's been a lot of conflicting information out there relating to these and how they should be used. There was information published and removed. And I think it's an area where they're going to be looking at, because in order to get claims to bypass these edits for a waiver of the 3-day hospital stay or a waiver of the spell of illness, then you have to code your claim in a certain way with a DR indicator that will enable it to be identified and will enable it to be subject to medical review. So when you do use one of these waivers, you want to make sure that you are doing them properly. So it should be included as part of your potential compliance risk, monitoring the frequency with which you use one of these waivers on your claims, and do a sampling of claims to make sure that you're evaluating their appropriate use. And there should probably be a team in place at the facility that makes these determinations when you are looking at someone to determine whether or not one of these waivers will apply. You don't want to put that responsibility just on one person. It should be something that you discuss among your Medicare team and make sure that you have good documentation to support how that decision process has been made. So CMS has waived this, the 3-day qualifying hospital stay, for individuals who have been dislocated or otherwise affected by COVID-19. Probably everybody in your facilities has been potentially affected by COVID-19, but this waiver applies to beneficiaries who experience dislocations or who are affected by that emergency. CMS also permits the benefit period to be renewed when individuals have exhausted their benefits and now have started the 60-day period of, they're counting down to have a 60 days of wellness to be entitled to have another benefit period. And if those individuals, if you have beneficiaries who have not been able to, because of the emergency, have not been able to end that process, that 60-day period of wellness, then they would be entitled to have a new 100 days under those circumstances. Now, these waivers are automatic. They do not have to be requested in advance. And normally these would be done on a regional basis when we have a hurricane or a flood or fires or some kind of those sorts of regional emergencies. But in this particular case, we have a national emergency, something we haven't had to deal with in 100 years. So when you look at this kind of environment, this is entirely different than the kind of 3-day hospital stay waivers, the 1862F waivers that we've had in the past. I think the most important thing you can do is make sure you document the decision process when you're applying one of these waivers. The goals that CMS has provided for these is to free up hospital beds to allow patients to enter SNFs and to limit the opportunities for further transmission of the virus. Those two are very important. And you want to, in order to make sure that you're addressing these compliance risks, document the evidence supporting your decision to use the waiver. And make sure that that decision process, your communication with the hospital, the communication with the physicians in the hospital and in your facility, the risk of the rates of infection in your particular community, document the entire process that you are using in order to apply one of these waivers to make sure that you don't get into a problem in this area. Notice of reporting requirements. This was just released a few days ago. And this relates to the CARES Act provider relief funds that we have received. We've received this initial notice. We knew that these reporting obligations were going to be issued. They said it was going to be in August. They didn't make the August deadline, and now we have received a notice just on September 19th. The links to it are included, and all these materials are included in the reference materials. And so you can pull these two notices down and you can read them. The September notice is 6 or 7 pages long. There's also a little brief kind of at a glance chart sort of looking document that the government has produced to make it a little bit easier to understand. I hope that helps because the requirements are relatively confusing, and I know people are going to look at it and say, this is not what they said before, this is not how I've been tracking it. What do I do with the information I've already collected? How does this affect what I'm doing? And this will be a whole entire topic for a subsequent presentation because there's so much to go through when you look at these new reporting requirements. So there are links at the end of the presentation. The portal to enter this information is not even going to be open until January 15th of 2020. The first reports required under this new reporting requirement is not due until February 15th of 2020. So you have time to figure this out. There are resources at the end. We're going to be offering a detailed presentation that will talk about how to do this and how to make the calculations. You should also be aware that that the Department of HHS has indicated that they are going to be offering sort of an open door forum for questions on these reporting requirements. And they're going to offer more than one of them. They've already committed to that. So I think they understand just how complicated these reporting requirements are going to be and what's going to be necessary in order for them to be well understood. And they are also going to have a list, a continuous list of frequently asked questions. And those questions come from the American Healthcare Association, the Healthcare Financial Management Organization, provider groups, providers who want clarification as to what exactly it is they're trying to say we need to do. And so you're going to see a whole evolution, just the way we have with all of the other frequently asked questions that are released out there that related to COVID. You're going to see a new start of a new list of questions that relate to these reporting requirements. So I'd encourage you to read them and ask questions and do your best to see how this needs to be, how you're going to implement this in your facility. Remember, the portal doesn't even open until January 15th, so you have a good bit of time in order to get this accomplished. So compliance auditing and monitoring, what's important with in order to, this is very important in order to make sure your compliance program is effective. Auditing, you need to have an objective evaluation of compliance in key risk areas. And the auditors that you use need to be independent of the tasks that are being done. This does not mean you have to go outside your organization necessarily. You can have someone else within your organization from a different facility, from your corporate office if you have one, or you can use outside people, but you want to make sure that you're evaluating these risk areas and that you're not having the people who conduct the activity evaluate their performance under that activity on their own. And monitor should be an ongoing process. You continually monitor in a dashboard sort of an effect. What are the important statistics you need to monitor in your facility based on all of the risk areas that we've identified? Which ones do you think are most important to your unique situation? And how are you going to monitor those? Which ones are you going to monitor? You can't monitor everything, so you really have to decide which ones are most significant and to update the monitoring process as circumstances change. And there are going to be new regulations and guidelines that affect compliance, as we've seen just with the new COVID-related regulations and rules that are affecting us. So those need to be incorporated as those rules continue to change. So it's a circular process of assessing risk, monitoring that data, monitoring the data that you've decided is important, auditing to make sure that you're complying with the regulations that apply to those high-risk areas, implementing a corrective action plan when you identify that there is some mistake in how the rules have been applied. And then you evaluate and update your risk, and you repeat the process again. One important thing there at the little audit circle is when you identify a problem and you identify an overpayment, you have to refund it. And we probably should have a circle just for that, but that's part of the corrective action plan. Here's what we're going to do to make sure that this error does not occur again. And these are the steps that we're going to take. And if we have a refund, this is how we're going to refund it. So internal benchmarking, you want to track your data in looking at some of those risk areas from the conversion to PDPM, historical data. You're going to get external data. There's a lot of information available in the public sector that you want to make sure that you're using and determining what your compliance activities should be. One of the important ones here is evaluating your PEPR information. They suspended PEPR for a while, but PEPR for skilled nursing facilities was released in July 29th. And in the state of Florida, only 24% of nursing homes have downloaded their PEPR report. Only 24%. In the state of Texas, I'll give you a couple of other ones. Texas, it's 18%. California, it's 12%. Half of the states in the country have a 0 to 19% download rate. Everyone's been so, I'm sure, consumed with COVID and all of that they haven't even looked and may not even be aware PEPR data is out there. And there's also PEPR information regarding readmissions that will be helpful to guide your compliance efforts under PDPM. So if you have not pulled that PEPR down, we would encourage you to do that. And there's lots of public data available also in the public arena that can help you identify where those risks are. Department of Justice, you can look at their press releases and their settlements and their prosecutions. You can look at the Office of Inspector General. You can look at the General Accountability Office, which issues reports that will identify areas of program vulnerability. And you can look at the CERT program, which is a completely random medical record review covering all fee-for-service claims that evaluates the error rate in Medicare fee-for-service overall. And overall, the error rate has been declining. At 7.3% was the last CERT review that was done. If you get a CERT review, it does not indicate anything is problematic at all. It means you've just been randomly selected to determine what the national error rate is and what service-specific error rates are. And as I said, the national rate is 7.3. SNF Part A error rate is 8.8. So we're above the average, which puts a little bit of a radar on our back. And outpatient Part B therapy is at about 14%. So there are a couple of areas there that you will want to have evaluate your risk in those areas. Are those important for you? And when those error rates are published, you want to take a look at those annually. We know we have the recovery audit contractors. We're now back in business. We have the fraud auditors, the UPICs. We have a couple of other ones that are listed here, including the Medicare administrative contractor, which has that train, probe, and educate. Haven't heard a lot of activity with those, which usually involve 20 to 30 claims being selected at once. And that would be a terrific burden in today's world. So right now, we haven't seen much activity in that arena, but these are places that you can go to identify potential. And how do you demonstrate that effectiveness? We've covered a lot of that already as we've gone through the presentation. Is your program reasonably designed to detect violations? It doesn't have to detect every violation, but what are you doing to make sure that you've identified the high-risk area and you're doing your best job you possibly can at monitoring them? What evidence of mandatory training is present? How do you train your individuals? How does that training vary from level of employee? How do you document the training that's been done? Do employees know where to go with concerns? Do they feel confident in the compliance reporting system? Do they feel like there might be retribution if they raise an issue? Is there consistent enforcement and discipline? You know, if the calls on the hotline go to the CEO of the company, that's not going to make people feel real comfortable. But wherever they go, it's important that employees feel like they can bring those issues to the compliance department, information on how to, feedback regarding those issues that they've brought. Do you at least review it annually and you update it? Is compliance incentivized when employees are reviewed? Is that their performance in compliance areas evaluated? Do you document personnel screenings? If you want to see a lot of enforcement penalties that have been applied, you can see that a lot of people have inadvertently hired someone who's on an exclusion list, and there's so many exclusion lists that you want to make sure that you've got a process pretty well automated that covers all of the areas, the different types of screening that you need to be doing. And when you have a compliance valuation, has it been addressed? Now, the Medicare overpayment rule, the 60-day refund rule, if you do have an overpayment and you've gone through, if you have an overpayment of any significant amount, you're more than likely going to get legal counsel involved to make sure that, number one, you've thoroughly investigated it, that you have done this under the attorney-client privilege, so it gives you time to investigate, that you make this disclosure in the appropriate level. There are multiple levels, and you don't want to go any higher than you need to. You can go directly to the OIG, but that's not likely something you're going to want to do. And remember this reverse False Claim Act potential liability. Now, what kind of damages can you end up paying under if you have a violation? They can take the amount of your overpayment and multiply it by 3 times. Then on top of that, they can add a civil monetary penalty of the damage amount from over $11,000 to $23,000 per claim. Those are the 2020 amounts. The overpayment amount times 3 times, then plus these per claim penalties, you're going to have a very significant potential overpayment. And that's why making sure that you're doing the best job you can to identify compliance problems is very important. You've got to we've talked about this, customize your risk areas. You should have updated your plan when PDPM was implemented. It's mandatory in the requirements of participation, so we know we need to do that. Under the federal sentencing guidelines, if you have a good and robust compliance and ethics program, they will give you credit for that. They will also give you credit for things like identifying overpayments. Maybe they come to you and say, we believe you have a problem in this area and we want to investigate that. And then you cooperate with the investigation along the way. You identify, we found another potential problem and we're reporting this to you. That can get you credit as well. And it helps ensure, you want to make sure you have a culture of ethics and integrity, and that it just isn't in the billing department, that it comes from the top down in the organization. It affects every single department and everybody is aware of it. So with that, we have given you a lot of reference slides. Most of the things that I've mentioned here are going to be listed on these slides. So you can go and pull them down, and as we mentioned, things change. So if you want to keep these bookmarked so you can change them or check them periodically to see if anything's changed, that's important as well. Here are the reporting obligations that I referred to. Happy reading. I think that's going to be the next important topic of conversation as we get into determining how we're going to apply and what's the best method of doing this. And as I said, we have time in order to be able to do that. I see we're very close to the end. If you do have any questions, I'll do my best to try to take some now. It looks like we're 2 minutes of our ending time. Also, make sure that you can contact me, and you can also contact our team at any time. And here's our upcoming webinar as well, so on the reporting requirements, so you can look forward to that. And with that, I appreciate very much your listening today, and if you have any questions, be sure to let us know. One last parting statement is I just know how hard all of you in the long-term care industry work, and it's your job is hard every single day. I don't mean to make it sound like it's even more, it can even be more complicated than what you have to deal with. But these are important areas, and our goal is just to help protect you and make sure that you do the best you can with all of these responsibilities. Jamie, should I turn it back over to you?
Sure. Thank you so much, Claudia. A lot of great information, and as she shared at the beginning of our presentation, we'll make sure that you all receive a copy of this deck. It'll be a great reference for you. As Claudia mentioned as well, we have another webinar coming up on October 8th that'll be around CARES Act grants reporting obligations, and we'll go over some FAQ revisions as well. So definitely keep an eye out for that information. We'll certainly send that to you via email. We also have another webinar coming up a little bit further out in November. We'll have one focused on single audit requirements, and that's been a big topic. A lot of questions coming in about that. So we'll have a webinar dedicated to that topic with Allison Jones joining us. So we'll make sure you receive that information as well. Thank you again for joining us this afternoon, and Claudia for sharing all your knowledge with us. We appreciate it, and we hope to see you all again soon. Thank you.